Assalamualaikum and good morning to Dr. Wati, Dr. Fairuz and all my colleagues lah. Today, I would like to share about insecticide and pesticide poisoning. Okay. Before we go into ABCD, which is important for resuscitation of poison patient, I would like to present about general management of poison patient lah. First, at the same time, we get the detailed history from the patient. If the patient conscious, cooperative patient, we should obtain the specific agent, times, route, amount and intent of exposure. If patient is uncooperative or third patient, we get information from the family, friends, the hospital provider, from the police, bystander. And then environmental clue is very important like suicide notes. And then if hospital records of the patient is available, we can review for any recent prescription of drug or patient has any history of psychiatric illness. And then we do full physical examination. We do for important we do from head to toe We search the entire surface of the body to search any clue that help in explain the condition of the patient Researching clothing and personal possession, and then review vital signs and perform physical examination Okay. Then we proceed to first principle of management of any syndrome. We do gross decontamination should be done prior to patient entry into the ED. This is very important to protect ourselves by wearing full PPE properly PPE wearing apron, glove and mask And then we go to what? Apa doktor?
Bukan apron, glove or mask. Glove, apron and mask.
And mask. And mask. Okay. And then we go to ABCD This is important in resuscitation of the patient. First, airway. Initiate airway protection by assessing patient speech. Look for airway obstruction and evaluate gag or cough reflex. And then for airway intervention, opening the airway. Examine the oropharynx for any foreign body. If there is secretion, we do suctioning, and then we can use airway device like oropharyngeal airway or nasopharyngeal airway and then we proceed to endotracheal intervention if indicated. And then B for breathing, determine if respiration are adequate, check SpO2 of the patient and give supplemental oxygen accordingly And then circulation, assess for blood volume status, most important blood pressure and pulse, IV access. We should get IV access and treat hypotension with fluid first, and then if still hypotensive, we can give anotrope. And then place patient on cardiac monitor and obtain ECG, because some syndrome can cause arrhythmia to the patient. And then lastly, disability. Perform neurology and mental status examination by assessing orientation GCS of the patient, check pupil size and reactivity, and then obtain capillary blood glucose and temperature. And then some patient commonly present as altered mental status coma. So we can give this called coma cocktail. Like supplemental oxygen for patient have hypoxia, and then for patient if having opioid overdose, we can give naloxone. If patient have coma in view of hypoglycemia, we can give dextrose. And then if the patient has venous encephalopathy, we can give thiamine
Okay. This is Izzatul. Saya kena stop anda di sini Ni dapat daripada buku mana nak bagi koktail ni?
Ada nama dia coma cocktail saya.
Yalah, dapat daripada buku mana coma cocktail ni?
Saya tak ingat dia punya nama web tu. Tapi bukan buku doktor, internet.
Bukan buku. Okey. Sebelum ramai orang mengamalkan ilmu coma cocktail ni, this is not something that we practice anymore This probably sebelum saya houseman masa saya houseman tu adalah sikit-sikit lagi orang buat benda alah ni. Tapi this should be your first line because altered mental status and coma, betul, agree, is a common presentation of many applicants. And I think for untuk kita pun, altered mental status is also a common presentation kat ED. And patient yang macam comatose or unresponsive, fairly common presentation kat ED, but you shouldn't, for all of these patient, bagi this coma cocktail. Jangan bagi. This is not something that we practice. Dia sampai tahap sudah dilarang lah. You nak bagi oksigen, okay. Tapi you don't give naloxone randomly to a patient that you suspect poisoning without first identifying or assessing the patient properly. Betul-betul naloxone, betul-betul ada overdose ke apa ke. Sama macam dextrose. You don't just give random dextrose to people. You know, ada DXT machine sekarang. You can check whether patient is hypoglycemia or not. Sama juga thiamine. It's not something that we practice bagi randomly to anyone. Okay. This coma cocktail ni ada asal usul dia. Dia bukan kata something yang completely wrong. Dia ada asal usul dia. Tapi it's not something that you should practice nowadays. This is from zaman dulu-dulu lah. It may have some use kalau awak kat overseas, because alcohol consumption is part of their culture. Kat sini jarang patient mabuk-mabuk every Wednesday apa semua for you to give thiamine. And alcoholic punya issue is not rampant dekat Malaysia. Bukanlah something that you see, you know, banyak datang kat ED kan. Most alcoholic that you see trauma je. You know, you rarely see patient yang ada alcohol intoxication datang, kecemasan dan semua. At least not in Kedah lah. KL cerita lain. Okay. So apa point saya nak cakap, coma cocktail ni jangan diamalkan lah. Assess your patient ABC, assess your patient punya actual problem dan sebagainya, and decide to give coma cocktail. Because coma cocktail ni, it can be dangerous, especially in patient who are chronically intoxicated, chronic abuser apa semua. Because a patient who's chronically abusing opioid, you bagi naloxone, you may induce withdrawal for this patient. You know, dia airway okay, breathing okay, tapi because you nampak dia macam drowsy sikit, you just bagi naloxone and you may accuse acute withdrawal in this patient, and patient may have a seizure in front of you. Sebab withdrawal kan, dia dah terbiasa ada opioid dalam badan dia, dan tiba-tiba you bagi naloxone, patient may become tachycardic, chest pain, and may have withdrawal. So may make the condition worse. Okay, so point yang saya cakap baby lama-lama ni, janganlah pakai coma cocktail. Okay, ajaran sesat sikit. Okay, teruskan. Tak apa.
Okay, and then if the patient have convulsion, check for anchored hypoxia or hypoglycemia. Give lorazepam or diazepam if it repeated and prolonged lah. And then okay, as secure reducing absorption of poison lah. We usually use induced emesis, but IPK syrup was once used frequently. But it may cause prolonged vomiting and aspiration pneumonia. So it's contraindicated lah to give to the patient if patient have reduced level of consciousness, absent gait reflex, and then some contraindication, petrol compound poisoning and convulsion. Usually we give activated charcoal, given within 1 hour lah. But downside of this substance is messy, unpleasant to take, and often cause vomiting. Aspiration into the lung can cause pneumonitis. And then sometimes we use gastric lavage useful if performed less than 1 hour of ingestion. Lavage is contraindicated in petroleum product poisoning, corrosive ingestion, convulsion, endoscopy or comatose patient. Gastric lavage is traumatic if applied. We only consider in specific condition only. Very rare to get patient within 1 hour presentation in ED. And then for bowel irrigation, to empty the bowel rapidly of solid contents by giving fluid down a nasogastric tube bowel preparation solution collide at 2 liter per hour until effluent is clear. Stop after 4 liter
Okay, okay. Hyperkakuan sirap ni adalah apa? Kita ada ke?
Apa sirap?
Kita ada ke? Awak yang tulis, saya pun tak kerti baca.
Saya tak pernah guna.
Okay, tapi not surprising lah because dalam awak punya notes pun it was once used frequently and this is an agent to induce vomiting. So you give this to patient so that patient vomit. So dia tak digunakan lah sebab vomiting tu may actually make things worse lah. Dulu pemikiran orang zaman dulu, if you ingest poison, make them vomit out the poison lah. Tapi then they realise that, you know, by inducing vomiting, higher risk of aspiration dan sebagainya lah. Or if compound is corrosive, of semua, you may actually end up causing the esophagus, apa semua jadi ni. So, induced emesis ni tidak diamalkan lah. Okay, good to know, jangan diamalkan. Okay, activated charcoal. Activated charcoal is something that we commonly use jugalah. I think at least you guys pernah encounter lah activated charcoal. Okay, so if patient present within 1 hour of ingestion, or you know that benda yang ingested tu is slowly tak diabsorb immediately, you can give charcoal. Tapi ada certain benda is contraindicated kalau nak bagi charcoal. Okay, tak semua poisoning boleh bagi charcoal lah. Most poisoning boleh, tak semua. You need to be aware apa benda yang contraindicated. Charcoal contraindicated to give lah. Okay, so dose 50 gram apa semua. Okay, gastric lavage. Pernah tengok ke gastric lavage? Anyone have seen gastric lavage? Pernah. Saya pun pernah tengok gastric lavage form sekali je seumur hidup saya, and that was in 2011 or 2012. Masa tu kat HKL. So that was 10 years ago lah yang saya pernah tengok. Gastric lavage ni pakai tube apa? Pakai rice tube ke?
Tube dia besar doktor.
Tube dia besar. Dia lebih kurang size chest tube size 30 ke. Tube dia besar lah. Tube dia macam batang pipe. So you actually shove that tube into patient punya stomach and you lavage lah. Lavage means that you buh air dalam tu, then you empty out the same amount. The trick with gastric lavage ni, you tak boleh push buh banyak sangat air, because if you put too much water in it, that water will push the poison out further into the stomach, into the bowel. You have to give enough, usually about 250, 100, 500. Then you have to drain out pula that 250, 500. Macam nak bilas perut tu lah. Okay. It's usually performed if patient presented in less than 1 hour post ingestion. Tapi unfortunately, macam Alia cakap tadi, jarang lah patient present within 1 hour. Yang kedua, the study around lavage found that it's not that beneficial anyway. Dia higher risk of aspiration, trauma dan sebagainya lah. Okay, it's not comfortable for the patient lah. Okay, so we don't do lavage anymore lah. Nobody recommends lavage as first line. And even kalau awak nak buat pun, tanyalah FA kena cari tube gastric lavage, takkan jumpa punya. Sebab dah tak ada dah. Okay, dia ada teknik, dia bukan just masuk tube je, ada position. patient punya position dan sebagainya. Okay. Whole bowel irrigation, pernah tengok tak whole bowel irrigation?
Tak pernah juga.
In what situation biasa whole bowel irrigation is done? Siapa-siapa pun boleh jawab. Alia, tak semestinya Alia, tapi Alia je yang ada dalam kamera ni. So, in what situation whole bowel irrigation is done commonly? Korang pernah dengar body packers tak? Keldai dadah.
Tak pernah dengar apa tu?
Tak pernah dengar keldai dadah?
Kedai dadah.
Jual dadah?
Guna
Keldai
body
dadah.
untuk transfer darah kan?
Wong nak kau Jalil cakap apa?
Use the human body to transfer the drug.
Body packers ni lah. Okay. So basically what they do is they put the drugs dalam kondom ke, biasanya dalam kondom lah. Then they swallow. So basically they store the drugs dalam dia punya colon lah. So bila dia sampai to whatever destination that's supposed to sampai, then they, tadah lah. So if these body packers ditangkap, they use this whole bowel irrigation lah untuk keluarkan. So basically literally, korang tahu komod tu apa kan? Wheelchair yang ada lubang tu. Yang untuk patient yang immobile, wheelchair ada lubang tu.
Yang untuk berak tu.
Buat balti kat bawah. Ni lah. Buat rice tube. Bagilah ni. Kau light 2 liter per hour sampai keluar semua. Sampai keluar clear air tu. Bila dah keluar air clear tu, maksudnya bowel tu dah bersih lah. There's no more, dah suci murni lah bowel dia. Dah keluar air yang jernih je daripada bontot dia tu. Dan baru itulah tanda bowel dia dah irrigated wholly lah. So, kalau awak sebagai pegawai polis ke doktor yang bertanggungjawabkan tu, tunggulah sampai keluar air yang clear daripada bontot kawan tu. Barulah whole bowel irrigation complete, and you inspect lah apa hasil di dalam tu. It's not common, maksud apa yang saya nak cerita ni, it's not commonly done for poisoning biasa-biasa. And sometimes it's not done for poisoning pun, it's done to clear the bowel content. For poisoning normally tak buat lah whole bowel irrigation ni. Sebab by the time dah sampai whole ke bowel ni, poison tu dah sampai kat bowel, it's fully absorbed already. There's no point. The reason buat whole bowel irrigation ni untuk keluarkan apa yang ada di dalam bowel tu. In the case of body packer, nak keluarkan drugs tu lah. That you can tangkap this person lah. And that tu sebagai bukti jenayah dia. So for poisoning per se, whole bowel irrigation tak buat. Because it does not prevent absorption ke apa of the bowel lah. Kalau kata one of the condoms tu pecah and then the content to get absorbed, you kena treat cara lain dulu lah. The whole bowel irrigation tu is nak keluarkan the rest. Bukan untuk as part of treatment of the poisoning tu lah. You nak keluarkan the rest, takutnya the rest pula pecah. Pasal body packers apa semua ni. Ni dunia-dunia benda-benda di unsavory dunia ni. So nanti satu hari kalau terjumpa tak terkejut lah. Tengok x-ray, fecal loaded ni. Bukan. Dia ada very specific features on x-ray. Okay. So basically dalam semua benda ni, yang you commonly encounter or buat in the case of poisoning adalah activated charcoal sahaja. Yang lain-lain ni good to know lah. Jangan pula tiba-tiba saya nak buat whole bowel irrigation kat patient kat yellow zone. Jenuh.
Okay. And then third principle, increase elimination of poison lah. For example, by forced alkaline diuresis, promotes excretion of drug with acid. For example, salicylate and barbiturate. But make sure renal function of the patient is good lah. And then extracorporeal technique, by peritoneal or hemodialysis, useful for salicylate, phenobarbital, and ethanol. By hemoperfusion, useful for short and medium-acting barbiturate, chloral hydrate, and theophylline.
Okay, forced alkaline diuresis ni buat macam mana?
Dia promotes diuresis lah, doktor.
Macam mana? How to do it?
Tak tahu.
Anyone have any idea? Jale? Bagi sodium bicarb. Bagi sodium bicarb to the patient. So before bagi sodium bicarb, you need to ensure that patient actually ada urine output. So kalau patient tak ada urine output, meaning that the kidney kong lah. And at the same time, macam mana awak nak buat diuresis kalau urine output tak ada? So that's one of the things that you need to establish sebelum buat alkaline diuresis ni. Kalau patient memang tak ada urine output, end stage renal failure ke apa ke, then this might not apply lah. Okay, kena extracorporeal technique tu lah.
Proceed.
Ni yang forced alkaline diuresis ni lebih merujuk pada poison yang dah absorb. Macam mana lagi cara nak increase elimination of poison, yang apa cara yang boleh digunakan untuk increase elimination of poison yang mungkin tak berapa absorb lagi?
Yang tak absorb.
Mungkin makan patient makan PCM kan solid kan? So tak adalah dia absorb, makan tu terus absorb kan? So the PCM might stay in tablet form dalam perut kan? How do you increase elimination of the PCM? Contoh lah.
Emesis tak boleh, doktor. Muntah tak
boleh. PCM ke, paraquat ke, pernah dengar Fuller's Earth tak? Macam mana Fuller's Earth tu berfungsi?
Dia macam charcoal juga kan?
Macam charcoal? Macam mana charcoal berfungsi? How does charcoal works lah? Alang-alang kita bercakap pasal charcoal kan? How does charcoal works to prevent absorption of poison? Okay, charcoal prevent absorption by binding to the poison lah. Charcoal ni dia macam kan awak nak mengurangkan bau busuk dalam kereta pun, nak charcoal apa semua. Charcoal ni dia macam sponge, dia absorb everything and prevent the poison from being absorbed by the body lah. Okay, Fuller's Earth pula, dia taklah bind to the poison tapi dia menyebabkan awak diarrhea. So tak sempat absorb, keluar lah. Paraquat apa semua tu, you bagi Fuller's Earth sampai diarrhea. Sebab dia akan keluar lah bersama Fuller's Earth tu. And of course not going to be absorbed. Fuller's Earth ni is type of macam clay lah, something like that.
Dia bind juga doktor dengan...
Dia basically, dia increase elimination. Macam charcoal, dia reduce absorption. Fuller's Earth dengan charcoal ni function dia different lah. So kalau baca buku teks biasanya kalau paraquat poisoning dia recommend suruh bagi Fuller's Earth sampai patient diarrhea lah to prevent to absorption of the paraquat lah. And you increase the elimination.
Okay. And then lastly, specific antidote lah. Good to know lah for common poisoning for antidote of the
Betul.
toxicum lah. This is list for common poisoning lah, for antidote for this toxicum.
So some of this need to be aware lah. Especially benda-benda common macam benzodiazepine. Korang kena tahulah antidote dia. Opioid. Kena tahulah apa antidotnya. So these are things that commonly given to your patient, and bila dah selalu bagi, selalulah overdose. Okay?
Okay. So we proceed to specific poisoning lah in insecticide and pesticide. First we go to organophosphate and carbamate poisoning. Okay, organophosphate insecticide include malathion, parathion and diazinon. Carbamate insecticide include metomil and ardicat lah. They are easily accessible lah and often used to commit suicide. Accidental poisoning may also occur, especially when they are kept within the range of children. Farmer would get exposed lah while spraying crops if they are not well protected. And then both can be absorbed through the skin, lung and GIT tract.
So the last part is very important. Important because this is why you need to decontaminate the patient. Sebelum masuk ED, baju, seluar semua kena decon. And kalau boleh mandikan sebelum masuk ED. Because ni dia akan above pada ABC. Sebab ni adalah D, danger. Okay, danger tu kena clearkan dulu. Sebelum masuk red zone ke yellow zone ke, you need to decontaminate the patient. Remove all the clothes. Kalau boleh mandikan patient, mandikan. Kalau boleh lah. Kalau ada decon room dan sebagainya. And this is also the reason why korang kena pakai PPE. Apron, glove, mask. Because all this you can get poisoned from the fume, or if patient tu baju dia penuh dengan paraquat. Lepas tu korang tanpa PPE menjadi hero, pergi pegang-pegang patient, can be absorbed through your skin. Takut yang nak menolong ni become poison juga. Because organophosphate ni dia, kalau pernah jumpa ke patient organophosphate?
Tak pernah.
Tak pernah tengok kan patient organophosphate poisoning kan. So by the time dah sampai kat ward dia dah wangi lah. Organophosphate ni dia ada distinct smell. Kalau patient datang poisoning tu, kalau dulu masuk red zone tu, the whole red zone will be smelling of organophosphate. Okay, so it can be very, dia senang fume lah, dia ada bau, distinct bau. So sebab tu kena pakai mask and kena decontaminate patient. And dia not just boleh minum skin, bau pun boleh menyebabkan poisoning. Okay.
Okay, mechanism of action. It inhibits acetylcholinesterase, which result in excess acetylcholine accumulation at the myoneuro junction and synapse. Excess acetylcholine initially excites, then paralyze neurotransmission at the motor end plate and stimulate nicotine and muscarinic side. Dia punya action, dia sebenarnya acetylcholine ni akan degraded lah to acetate and choline. Cuma dia organophosphate and carbamate ni akan inhibit this acetylcholinesterase. So acetylcholine ni dia akan access lah, and then dia akan stimulate activation of receptor nicotine and muscarinic receptor. This mechanism of action lah. And then we go to clinical picture lah of muscarinic and nicotinic effect. The sign symptom will develop 12 to 24 hours lah after injection. There is a mnemonic lah for muscarinic effect. D for diarrhea, U for urination, M for meiosis, B for bronchoria, bronchospasm and bradycardia, E for emesis, L for lacrimation, S salivation, S sweating lah.
Just remind, symptoms tu 12 to 24 hours tu dia bergantung kepada jumlah yang dia consume. So tak semestinya 12 hours baru develop symptom. Kalau dia consume the whole bottle ke, or highly concentrated version ke, almost boleh kata almost immediately patient akan develop symptoms lah. Okay.
Hmm.
Bukan kata semestinya 12 hingga 24 jam baru ada symptoms. Can almost immediately develop symptom if patient ingest enough dose. And usually patient tak tengok dose pun sebelum ingest kan. Kalau dia minum banyak-banyak lah. So 12 to 24 hours tu macam lupakan lah.
Okay.
Tapi
And
the
for
symptoms tu jangan lupa lah.
apa doktor?
Bells tu, the symptoms tu jangan lupa lah. Lupakan lah 24 jam tu lah.
It can develop rapidly, like immediately after injection. And then dumbbells, 3Bs, bronchoria, bronchospasm and bradycardia is life-threatening lah for the patient. So, okay, and then for nicotine effect, muscle cramp, tachycardia, muscle weakness, hypertension, fasciculation, hyperglycemia. CL can give also CNS effect, anxiety, restlessness, tremor, convulsion and coma lah. Okay, so the muscarinic effect tu the wet symptom lah, but the most dangerous, life-threatening, we need to remember these 3Bs lah: bronchoria, bronchospasm and bradycardia. Okay. For investigation, as usual, we will send baseline blood, and then insecticide may be identified in urine on toxicology screen. For plasma cholinesterase gastric and serum toxicology specimen, we can send, but it can give result too lambat lah. So usually we will start treatment lah walaupun tak keluar lagi result. We will treat according to the clinical presentation lah, because plasma cholinesterase gastric and serum toxicology specimen ni dia outsource, dia lambat lah result dia keluar. And then we do the ECG, chest x-ray and CT brain. Okay, and then for supportive measure, all staff, this is important lah, all staff member required to wear protective equipment, start detoxification lah by removing patient clothes and washing the skin properly, maintain airway patency, perform intubation if patient obtunded apnea and has no gag reflex. Frequent suctioning may be required due to bronchoria. Administer give supplemental oxygen if required, and then monitor ECG, vital signs, get IV access and administer IV fluid lah. And then for drug therapy, we give activated charcoal, gastric lavage tube, and then the most important atropine lah. It's a life-saving drug. It's muscarinic receptor antagonist. Major use in the reduction of bronchoria and bronchospasm. Dia punya dose 0.5 to 2 mg given IV every 5 to 10 minutes until atropinization is adequate lah. Dia tak ada maximum dose.
Untuk just for your expectation lah. Awak rasa berapa banyak dos atropine nak bagi kalau patient datang full blown organophosphate poisoning lah, yang sampai heart rate dia 20 lah, heart rate dia 20, patient basically unconscious, okay, orang dah start CPR. Awak rasa berapa dos atropine nak kena bagi baru patient respond? So you have to estimate kan. Awak cakap tak ada maksimum kan, agak-agak berapa dos nak bagi atropine?
Saya ada baca dia tulis 400 ke 1500.
Bayangkan atropine satu ampule tu berapa mg?
Satu tak pasti. 1 mg.
Biasanya kita bagi untuk bradycardia 0.5 mg kan. Patient organophosphate saya pernah nak sampai patient atropinize je 200 mg. Basically habis atropine satu department. Lepas tu awak nak start infusion pula, habislah atropine satu hospital. So don't worry about over atropinization ni lah. Kalau patient memang dah datang full organophosphate poisoning, you kena dalam minda you ni, oh dah bagi 5 ampule tak respon lah. Bukan sometimes you need to give 100 ampules baru patient respond. So be aware, that's the sort of level yang sometimes you nak kena atropinize the patient, baru patient ada respon. 100, 200 mg of atropine. Sebab patient akan datang dengan the common signs yang akan nampak, patient ada banyak secretion, pupils dia constricted, dia heart rate dia brady. So you nak kena bagi sampai pupil dia dilated, heart rate dia more than 80 and dia jadi kering. Whatever secretion dalam mulut dia jadi kering, yang peluh-peluh tu semua kering. So jangan ingat dah bagi 20 mg ni tak respon lah. Kenapa tak respon? It just means that you haven't given enough lah of atropine. So dia bukan level sikit-sikit ni, level yang macam masa you dah nak bagi tu pun dah kena kerah dah misi untuk mengumpulkan semua atropine yang ada kat department lah untuk digunakan. So a lot, 100, 200 mg of atropine. So just be aware lah. Cuma susunan management awak ni pelik sikit lah. Investigation dulu baru drug therapy. Macam Alia cakap tadi, memang investigation akan lambat. Usually you dah tahu dah patient tu consume organophosphate or even clinical features, then you don't wait for investigation untuk start all the drug therapy, benda macam charcoal and atropine. Jangan tunggu big investigation. Once clear patient punya ABC, you need to immediately give atropine because this is the antidote. Selagi tak bagi atropine, the likelihood is patient is not going to survive. Jangan fokus kepada investigation, whatever. Treatment ni, antidote.
Charcoal tu kita bagi juga tak, doktor?
Apa dia?
Charcoal bagi juga tak sebelum?
Patient tu dah tak sedap. Dah macam datang tu dah full blown organophosphate poisoning, charcoal tu will be a bit pointless lah because charcoal ni nak prevent absorption. Kalau patient tu dah datang full blown organophosphate poisoning, maksudnya dah absorb dah lah. So, give the antidote lah.
Okay. And then patient anti-atropinization manifested by drying of tracheobronchial secretion, dry mouth, flushing, heart rate more than 120 and dilated pupils. Patient should be kept well atropinized for at least 5 to 7 days by either intermittent administration or continuous infusion. But we should watch out sign of over atropinization, very dry mouth and skin, pulse rate more than 160 per minute. And then pyridoxine. Pyridoxine works by reactivating acetylcholinesterase that has been bound to organophosphate molecule. Effect are mainly escalator neuromuscular junction nicotine effect. Effect will be apparent within 30 minutes, which include disappearance of convulsion and vesiculation, improvement in muscle power and recovery of consciousness. Adult 1 gram lah, IV over 15 to 30 minutes can be repeated in 1 to 2 hours as needed. In children, 25 to 50 mg per kg. Intravenous over 15 to 30 minutes can be repeated in 1 to 2 hours as needed. And then diazepam used to reduce anxiety, restlessness and to control convulsion. Dosage 5 to 10 mg intravenous lah. Okay. Actually carbamate and organophosphate poisoning is similar, except for inhibition of cholinesterase is reversible within 24 to 40 hours, so manifestation are less severe and or shorter duration lah. And then poor penetration of blood-brain barrier, leading mild or no CNS manifestation. Atropine administration is adequate. Pyridoxine should not be given as it may worsen the symptom. This picture kalau tengok pyridoxine dia akan effect dekat enzim muscarinic receptor tu. So kalau organophosphate poisoning, pyridoxine will bind to the free and ion side of receptor lah. So when dia bind dekat free side tu, dia akan bawa organophosphate tu jauh lah. So reseptor tu akan free lah. Tapi kalau carbamate poisoning, dia akan bind dekat both side, bukan dekat free side saja. So there is no reactivation lah of the enzyme. So it may worsen the symptom kalau kita bagi pyridoxine dekat carbamate poisoning. So I move to paraquat poisoning. Okay, for paraquat poisoning, it is a toxic chemical that is widely used as herbicide lah, plant killer, primarily for weed and grass control. It is reasonable safe to use in agriculture. Dermal or spray exposure generally causes only limited and localized injury. However, accidental or deliberate ingestion has an extremely high case fatality rate lah. Macam mana kita boleh dapat dengan paraquat ni? Intestinal injection, long term skin exposure dengan inhalation. The mechanism of paraquat, after absorption, paraquat is concentrated inside many cells where it undergoes redox cycling. This a process involving repetitive enzyme mediated cycling between paraquat and paraquat radicals, and it will produce superoxide radical. It a highly reactive oxygen species lah. It will cause direct cellular damage. And then paraquat ni dia punya main target organ adalah lung lah. And 60 to 80% mainly due to acute lung injury and progressive pulmonary fibrosis. Paraquat also causes renal and liver injury. So paraquat ni kalau kita bagi kalau oksigen tak indicated for the patient, so kita tak akan bagi paraquat because it will lead to lung pulmonary fibrosis lah. Okay, injection of smaller.
Why kalau patient paraquat poisoning, if possible, tak perlu bagi oksigen because oksigen tu can aggravate the production of ni lah paraquat radical sampai semua. So walaupun niat anda baik, the oksigen yang anda beri tu kadang-kadang boleh menyebabkan pulmonary fibrosis tu berlaku dengan lebih cepat lah. So if possible, kalau patient tak tachypneic, saturation boleh maintain, jangan bagi oksigen lah. Tapi kalau perlu, kena bagilah juga. Tapi if possible, try to avoid oxygen as much as possible because you may cause worsening of the lungs lah. Okay.
Clinical feature, sign and symptom of toxicity are dose related and error dependent. Injection overwhelming vital dose is followed quickly by hypotension, restlessness and death. Initial period just nausea and vomiting. Also, usually presentation there ulcer in the mouth and esophagus, diarrhea, abdominal pain, epistaxis, pulmonary edema, hepatocellular necrosis, acute renal failure and later pulmonary fibrosis. This investigation lah, gastric lavage or urine for paraquat, ABC are baseline lah and chest x-ray lah. Chest x-ray measure.
Dalam botol coke tu paraquat lah kot.
Yang ni paraquat dia hijau pekat. Gelap lah. Betul tak betul?
Kalau patient minum yang mana tinggal dalam botol coke tu, pretty much matilah. Okay, bila cakap large amount of paraquat ni, bukan 100cc, bukan 1 liter. Large amount of paraquat ni 10cc je. It's almost fatal lah. 5 to 10cc paraquat injection. Kalau yang concentrated lah. Almost always fatal lah. And biasanya not immediately pun. Patient will die lah within a week. And nowadays, kita buat dialysis, kita bagi, lupa dah. One of the chemo drugs, so apa semua. Sometimes helps lah. Tapi kalau survive pun survive dengan serious disability lah. Most don't survive lah. Tak payah banyak, 5 to 10cc je.
Okay.
So not every kalau nak menarik perhatian suami, boyfriend atau semua, you know, take PCM lah. PCM probably safer lah. Paraquat, you're doomed dia lah. Okay.
Okay. And then for management, contaminated clothing should be removed immediately lah. Contaminated skin should be washed with soap and water. Insert nasogastric tube, stomach wash out as soon as possible, activated charcoal, and then IV fluid. for 4-5 liter per day for the first 24 hours and then 3 liter per day lah. Per orally and IV for several days to maintain good hydration. Potassium supplement, furosemide, hemolysis or charcoal hemoperfusion may be useful if started very early, especially within 5 to 7 hours of ingestion before the distribution of paraquat into tissue, especially the lungs lah. And then this important oxygen to be avoided lah unless PO2 falls less than 60.
Yes,
And then okay, for population is unless patient is severely dyspnea lah, because oxygen tends to increase the toxic effect on the lungs. Okay, that's
Okay, saya dengar.
This is last lah. Take home message for insecticide, pesticide poisoning or any poisoning lah. This is general principle of management of any poisoning. First, decontamination of the patient lah, and then ourselves also lah, and then reduce absorption of the poison, increase secretion or elimination lah of poison, and good to know the specific antidote lah for the toxico.
So, kalau tak ingat apa-apa pun dari presentation Alia hari ni, slide last ni lah. Principles of management of poisoning, any sort of poisoning, decontamination, reduce absorption, increase elimination, and specific antidote. Okay? Decontamination, reduce absorption by giving charcoal, increase elimination by giving benda macam fuller's earth, and specific antidote lah. Kalau opioid poisoning, bagi naloxone, benzo, bagi flumazenil, organophosphate, bagi atropine, dan sebagainya lah. Dia bukan if you know that agent yang menyebabkan poisoning to have specific antidote, if available, you need to give the specific antidote. Because whatever else that you do is considered supportive care sahaja. Macam paraquat dia tak ada antidote. So you support lah the patient. You help to eliminate the paraquat by doing dialysis and whatever. And then berdoa lah. Semoga panjang umur. Kan? Mati dalam kurang penderitaan. Any question kepada Alia? Tak ada jelas. Clear as mud. Okay, saya tak ada apa-apa dah. Siapa-siapa nak memberi pendapat, nak menanya soalan, tetapi tengah drive ke? Okay, tak ada apa-apa. Saya rasa sampai di sini sahaja. Hari Khamis kita dengan Khairul kan?
Betul.
Khairul Anwar ni kan?
Khairul Anwar.
Ya saya. Saya punya hari Khamis saya doktor.
Hari Khamis.
Minta maaf nah.
Swab dah?
Swab dah.
Okey. Dengan HSAH ni. Okey.
Okey doktor.
Okey.
Terima kasih doktor.
Okay, thank you doktor.
Thank you, doktor.
Terima kasih doktor Wati. Terima kasih semua.
Terima kasih semua.
Okay, thank you.